I know you have done this before, and so I'm just hitting record right now just so that I can cast it out and make sure that it's linking properly, and then I'll hit live on Facebook, and we should be good to go.
Perfect.
Okay, it looks good. Okay, so I will run through just super fast announcements, and then I will just bring you in with, you can just briefly introduce where you're from, and well, I'll say where you're from. You're from the Mayo Clinic in Minnesota, correct? Okay, awesome. All right, well, thank you guys for, wait, hold on, go live, click. YouTube is going to be fun. YouTube caught all that, but it's fine. All right, you guys, thank you so much for joining us on the I Believe podcast. We are here with Dr. Lauren Dalvin from the Mayo Clinic, and I'm actually super excited to have her because if you guys didn't see what was happening this last week, there was actually a conference specifically for eyes and eye health, and we'll get into that in just a sec. But just so that you guys know, kind of by way of information, just in case anybody else is maybe just not following Facebook or you're not getting our email updates, we do have a walk that just happened this weekend in LA. So if you're from LA and we have the next date up on the website, just watch for that. Get registered for next year if you plan to attend next year, and tell your friends and family in the LA area. We've also got the Scottsdale Looking for a Cure that's coming up this Saturday. That's where I'm going to be. Myself and Dr. Mosier are super excited, and we have a huge crowd already planned to come out. I think we're pretty close to beating Palo Alto. I'd have to double check the numbers, but I think we have to beat Palo Alto by having 244 people registered, and last I checked, we were at 241. So we were pretty close. Anyway, so Scottsdale coming up, and that's on November 19th. Please come and register, come walk with us, or just consider donating. And then the last couple that we have this year are going to be in Houston and in Dallas-Fort Worth. Dallas-Fort Worth is on December 9th, and Houston is on December 10th. Yes, I keep track of all of this information in my brain. It's a mess. But I am so glad to have Dr. Dalvin here with us. So Dr. Dalvin, thank you so much for joining us.
Thanks again for having me. It's always a pleasure to be here with you.
Well, we are so glad to have someone just as excited and passionate about what you do here on the podcast to talk to us. And I know I kind of put you on the spot for this one, but we are hoping that you can share a little about what happened at the American Academy of Ophthalmology convention that you were attending this last week.
Absolutely.
And kind of, I guess, where did ocular melanoma fit in this?
Yeah, this is really, for ophthalmology, probably our biggest clinical meeting of the year. So this is a huge endeavor. And every subspecialty has its own little section, and we have our own subspecialty society day as well. So our subspecialty society is the American Academy for Ophthalmic Oncologists and Pathologists. So we get a really big, long name. But it's a really awesome collaborative group because we get our ophthalmologists, our pathologists, and we actually had medical oncologists as well come to this meeting. And so we've had an opportunity to talk about some really exciting things coming up for patients with uveal melanoma. And so I just thought I would touch on 3 clinical trials that are already or about to get started that may be of interest. And so number 1 is a trial for patients who have not yet had their tumor treated. And this is with Aura Biosciences. And you may have heard about the earlier phases of this trial. It's now moving into a phase 3 trial where they do a suprachoroidal injection of nanoparticle therapy. And these nanoparticles are designed to hone in on the cancer cells. And then we can use a photodynamic therapy laser to activate those nanoparticles to kill the cancer. And so this is going to be for patients who have potentially smaller tumors, tumors that normally would really devastate somebody's vision if we had to treat with radiation. So sometimes we hesitate on treating these tumors because it's such a big thing to lose vision. So the hope is that this is going to be potentially an effective treatment that can do something good to cure the cancer without harming vision. So this is really exciting for the future of our patients.
No, this
And I'm
is so
hopeful.
cool.
It's
So
very
cool. I
cool.
mean, I just know, personally a handful of patients who have had smaller tumors and they've lost vision because it was too close to the center of vision, or it was too close to the optic nerve, or just something went whack and they didn't expect them to lose vision, but they did. And this is seriously going to be life changing. So I guess, if you're listening on Facebook and you see someone who is about to have treatment and they have a smaller tumor, or they've posted, hey, I'm looking for a doctor, or I'm looking for this, make sure to tell them about the ARA trial and make sure that they are checking with their doctor to see if that's an option. Obviously, like you said, it's not going to be for everyone. It does sound like it's for smaller tumors, which is not going to be every single tumor, but that is still something that, we on Facebook can help catch those people before they head into surgery for plaque on a 2 millimeter tumor that can be treated this way.
Yeah, I think it's absolutely going to be game changing for some patients. And then on the other side of it, for patients who do go on to have radiation, there's a trial with the DRCR network, which has been a big force in things like diabetic retinopathy. So, this is a major group that's used to doing big clinical trials in retina. And we're so lucky that we now get to come together as an ocular oncology community and have one of these trials for patients to hopefully see if we can prevent or better manage radiation retinopathy, radiation side effects after we do something like plaque or proton for uveal melanoma. So these patients in this trial are potentially going to have steroid treatment or anti-VEGF injections, or we're going to watch and wait, which is a lot of times what we do. And we're going to see, is doing something right away the best option? If doing something right away after treatment is the best option, should that be anti-VEGF or should that be steroid? Or should we wait and see? And at what point should we start intervention? And the reality is, we have very little data on all of this because we've never had a good prospective trial. And so this is going to answer a lot of questions for us in our field. And I think this is really going to help us hone in on what can we do to best preserve vision, even when we do have to do radiation.
So just to clarify, these are going to be, they should have already had or be coming up on radiation treatment of some kind. Would that include proton beam therapy as well as plaque?
So this is, I think, primarily going to focus on plaque radiation, but
Okay.
the same principles are going to apply to all of our
Gotcha.
patients who have any type of radiation. So this is really going to inform, I think, how we treat anyone who has radiotherapy for uveal melanoma.
Gotcha.
And the time that you want to say something is really before you get treated, because you do need to have a screening visit and they do need to do some particular images and some particular types of treatments, like a steroid injection at the time that you're having that radiation treatment. So, if you're interested in participating in something like this, you want to say something early. And this is going to be ready to open quite soon. And there are going to be a lot of centers. We've done a really great job of coming together as a community. And fortunately, because the retina doctors are so used to working with this DRCR network for other trials, we have a lot of our retina doctors on board too. So hopefully that's going to make this trial more accessible.
Awesome. Okay. Excited about this. And like you said, this one is up and coming, not quite open yet, but will be recruiting very, very soon. And just to backtrack, the Aura Biosciences, that one is recruiting now.
So that one is up at some sites and getting rolling at other
Okay.
sites. So they are ready for recruitment. I don't think that we've gotten our first patient yet because we do have a little bit of a narrower window on exactly
Yeah,
the
for
right
sure.
patients for this trial. But that one is ready to go.
And do you know, in a phase 3 trial, how many patients are they hoping to potentially have in a phase 3 trial?
Yeah, I believe it's somewhere around 80 patients.
Okay. So, and realistically, like you said, because it's such a narrow type of patient and a narrow size of tumor, this could take a little while. But the fact that it's in phase 3 is a good thing, right? Phase 3 trials are always going to like present a little bit differently. And phase 3 means they're comparing to, doesn't it mean they're comparing to standard of care treatment? Or is that not the case with this specific phase 3?
Slightly different. These are, potentially really early stage tumors where sometimes the right option for that tumor might even be observation, because they're not necessarily definitively need to have radiation cancers that are all in this study. So they're not going to be necessarily comparing to plaque. If patients don't do well in the treatment, they're going to be eligible, of course, to go on to receive that standard of care plaque radiation. But this is going to compare to an observational arm.
Okay, that makes sense. Thank you for clarifying that. Move on to number 3. What was the third one that you heard about that was super exciting?
Yeah, number 3, I think I am most excited for this. So this is from IDEA, and from IDEA, there's actually 2 studies. So there's one study that's really probably going to be driven by the ocular oncology community and one that's going to be driven by the medical oncology community. So from our standpoint, we are really excited to have a neoadjuvant to adjuvant trial. And these are big words. So let's talk about what these mean. So neoadjuvant is going to be for patients who have not yet had any treatment for their eye melanoma. And they're going to give a drug called darovasertib to try to treat the eye melanoma before we do anything else. So there's going to be two arms in this trial. One is going to be really big tumors that would otherwise have to have an eye removed. And the hope is that by giving this drug, we can shrink the tumor and avoid eye removal. And the second arm is going to be patients who would otherwise have radiation. And we're going to try to shrink the tumors and hopefully give a lower radiation dose. So, neoadjuvant meaning that we're going to give this before we would do our standard of care treatment. And then for patients who tolerate the drug well and who hopefully have a response, they can move into this adjuvant phase where they're going to continue to receive the drug in the hopes that maybe this can reduce their risk of developing metastasis in the future. So, I think this is really exciting having that adjuvant phase and potentially being able to save eyes or again reduce radiation dose that can preserve vision is really going to be a game changer. And on the medical oncology side, they're going to combine this drug with crizotinib and they're going to try to treat metastasis. And so I'm really excited to partner with our medical oncologist here. And I know a lot of my colleagues are so excited to partner with their medical oncologists at their institutions so that we can offer both arms of this trial to our patients.
Oh, that's going to be so exciting, and I love that this is really just. I mean, everybody's trying to cover, or at least it seems right here, like that. IDEO Biosciences is really trying to cover everybody. They're trying to cover from the beginning of diagnosis all the way through to metastases, and obviously, we hope that nobody ever has to deal with metastases, but we know that's not the case. That I mean, it's just not how it has worked historically. And I also am like sitting here thinking about your living library and how that like relies on enucleation, and I'm like, well, I guess like if it doesn't work and enucleation still works, then a living library part can still be an option. But anyway, so I'm just sitting here thinking like just for you and what you've talked about before, I'm like, oh, obviously we don't want to enucleate if we don't have to, like speaking from experience, but also like this is just going to be neat. It's going to be neat to see how this goes. So I look forward to hearing more from them, and I would assume that we can probably follow, like for just research updates and things, probably just IDEO Biosciences directly. I know what do you call it? Their newsroom or their like news updates. They're pretty solid about updating about what's going on. So anyway, well, that's so awesome. Thank you so much for sharing just kind of directly what was going on last week. I know Melody and Suzanne were there representing a Cure in Sight at our booth for patient advocacy and just networking and talking to all of the doctors and the physicians that were there. But we are so grateful to you guys who are, 100% part of the team and part of this movement to try to make sure that ophthalmology knows about OM and that we teach about it, but also that we have some really awesome avenues of treatment. So this is super exciting stuff.
Yeah, I think it's fantastic. And what a great era that we now have all of these clinical trials popping up. If you go back just a few years, we weren't talking about clinical trials at our academy meetings. So that
Mhm.
is so exciting to me that we are now.
No, and it's so powerful too that like I love the idea that they already, because they've already got the metastatic treatment. Like in the past when, we've discussed this idea of adjuvant treatment, it's been that we have to wait. We've had to wait to know um, does it work in the metastatic setting first? And if it works in the metastatic setting, then we can go back and we can attempt, initial treatment and then adjuvant treatment or, something like that. But because of, kind of the way that this trial has been structured and these two arms have been structured, it's basically contingent on, do you respond well for primary treatment? Yes. We already know you have a large tumor. You probably have a high risk of metastases just based on size, like biopsy aside. So we're just going to assume you need this medicine to keep going. Like that's just, to me, that's so smart. And I hope that we can continue seeing that pattern as more research happens with other drug development companies. Anyway, okay, well, is there anything else from AAO that you want to cover that you're excited about?
I think those are the big things. It's such a great meeting, and I just love that we continue to build our collaborative community.
La 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 la. I have a personal question I will forward on to you in the future. I'm not gonna. not going to chat about this one live, but just keep in mind as you're listening live, personal medical advice cannot be distributed over the internet, but we are happy to answer questions. Just send those in through the Facebook or the YouTube chat, and I will front those to Dr. Dalvin where she can see them. But we're going to move on to our main topic, which is to just chat about really just the patient journey through OM, and just how this can look for people, with the caveat that we're going to talk about this, I guess, as generally as we possibly can, but it really looks so different for everyone. And so that's kind of one of the caveats to this conversation. So, Dr. Davin, I think when we had talked in our outline, you had said to maybe have me kind of just outline my initial diagnosis, like
Yes,
experience. So, do you
I
want me
think
to do that?
that's so important to understand what it feels like as a patient to get this type of news. So I really wanted to hear your perspective.
Okay, so for me at least, um, this was something that was completely out of the blue. I actually lost vision pretty suddenly, just kind of overnight in one eye. It just diminished really rapidly. And within a couple of days, I had decided, okay, something's off and it's not getting better. So I should probably call my doctor. So I did. It was a Friday morning. They got me in right away because they were like, oh, wow, that's not good. You need to be here like yesterday. And so I went into my ophthalmologist office, and the optometrist did some imaging, and she, dilated my eyes, and she just couldn't really see much. And the picture that she showed me, kind of comparing eyes side to side, just showed a lot of black. And it wasn't a very high definition image. And so she just told me, I think that you just have some bleeding under the retina. We probably need to just send you in for emergency retina surgery. And like the way that she's explaining it, it's like, this is a big deal, but also like, we can fix this. And so I was sent literally within 45 minutes of her telling me that they had an appointment lined up for me at another retina doctor, or at a retina specialist office. And I was shuttled over there by my mom because my eyes were so heavily dilated to look at everything that I just couldn't drive. And waited in the office. And of course, it's the height of the pandemic. And so we're all masked. And I just remember like taking this picture of like, I'm here. I'm supposed to have my retina fixed. Apparently it's torn. Um, and that was what I was expecting was, my retina's torn and I need it fixed, and obviously not great, but like fixable. And so I went in through this doctor's office and went through all the tests. They did, some various dye tests. They did, I think by the time we finished, with all the photo type tests, then they did an ultrasound. And I remember the ultrasound was probably the most uncomfortable part of it because you're like laying in this chair and they're like, the nurse has me like tipping my head like as far back as I can, and she was on my eye for like at least 30 minutes. And it felt like an inordinate amount of time. And I was just like, but at this point I still had no idea. I just was completely expecting that I was going to be getting, retina surgery that day, and that they just needed to have good ideas of what was going on in my eye to do that. I come in, or the doctor comes in, and he just says, why do you think you're here? And I remember that his name was Dr. D'Souza, I think, or maybe it was Souza, but I nicknamed my tumor after him because it was just it was just a way for my brain to make some kind of fun out of this. But he just said, why do you think you're here? And I told him, well, I have a torn retina and it needs fixed. And he said, well, you do have a torn retina, but I can't fix it like today. Maybe I can fix it in the future, but we actually need to treat, like, there's an eye tumor. Like, we need to treat the tumor first. And it was like kind of like one of those moments where you feel a little separated from reality, maybe. And like I just remember, like, I heard him, and like the word went in and then it went out, and then I just didn't quite like it literally, it was a Friday afternoon. He told me, don't go on Google. And I just remember thinking, a tumor, like, that's not good. But like it just hadn't quite fully connected in the office yet to cancer. Tumor and cancer didn't quite coexist in my eye yet, because it was like, an eye cancer, like what? Like, that just didn't exist for me. I've never heard of this. I guess apart from retinoblastoma, which I know occurs in children, but even that I hadn't heard nearly very much about. So it was a complete shock, honestly, like just for me getting that initial diagnosis. Um, Fast forward a little bit, and I had, another appointment with an retina specialist who treats the cancer. And then after that appointment and walking through, what do we do? Um, what kind of treatment options do we have? Which they were basically telling me we can do plaque or we can do enucleation. It was large enough for that. I didn't feel ready for enucleation, and he was telling me I feel confident to do I feel confident to do plaque. I've treated tumors this big before with plaque, and I feel good doing this. He just basically told me it was on the cusp of like, well, we could go either way, kind of on that border. And it was also located at the front, which he said had really good access for doing a plaque. Um, Anyway, I ended up wanting a second opinion because, when you get that final diagnosis of, yes, you have ocular melanoma and here's how it can go. I remember someone in the office telling me, like, because I was like, well, do I have to decide now? And he said, well, you need to do it soon because if you don't, you're going to die. Like those were the words out of his mouth. And I was like, well, thanks for being blunt. um, and all this time too, like all of these tests, all of this stuff that's happening in this office, because it was the pandemic, I'm by myself. Like I can have a care person in the room with me with the doctor when we finally sit down with the doctor. But like all of the tests, all of the things that are happening behind the scenes, it's all just me by myself. Um, which I think, now maybe that's still normal. I don't know. But it felt really isolating at the time. Um, and then I ended up meeting with my next doctor and choosing to stay with her. And she's actually the doctor who ended up referring me 2 years later for enucleation because turns out front tumors, anterior tumors are not so treatable with plaque in the sense that they deteriorate the eye tissue too fast because the plaque, or they can. So my plaque ended up deteriorating my eye enough that I had enucleation 2 years after plaque, or a little over 2 years. And that was not because of pain, thankfully. It was simply because the eye itself was kind of deteriorating, coming apart, and exposing the tumor underneath the sclera, which was a little freaky. Um, anyway, so that was what it looked like, kind of just from the beginning to fast forward to now. And I think some in our community know that I have metastatic disease or a metastatic diagnosis. That was a year ago, and I am a year out from that, and I am currently cancer free. So we're gonna cross our fingers and cross all the things that continues to stay that way with the things that I've been doing through just my doctors and my naturopath oncology team. So that's where I'm at.
Thank you so much for sharing that. It's such a common story. Thinking that there's a detached retina, this sudden loss of vision, and the seeing multiple doctors. I think these are so frequently part of the uveal melanoma patient story. And many times I get people into my office who really still don't quite know what's going on, or they've been told that they have a tumor, but they didn't understand that that was a cancer. And that's really something I've learned over time, that you really have to say the word cancer for somebody to understand, because it doesn't always sink in otherwise. And the reality is, for better or worse, we don't want a lot of patients to be affected by this, but most of the time the doctor who picks this up may never have seen this before. And they're scared and they don't know how to have this conversation either. And so, unfortunately, sometimes it doesn't come out the way that we wish it would. And they try to rush and get you to the next person who maybe knows a little bit more. But it does feel abrupt. It does feel terrifying. And the don't Google is such good advice, but it makes you want to do it all that
Well,
much
yeah,
more
especially
because you
going
just
into a
want to
weekend,
know.
right? You go into this, which I can't tell you how many patients I know who have said I was like my tumor was found on a Friday, and the next time I could see like an ocular oncologist or get into whoever I travel to go to get treated, it was like a Monday or a Tuesday the next week. So like of course you're sitting all weekend like twiddling your thumbs, trying to stay busy, like wondering what is this? What does it mean? Google, do you have answers? Wait, I don't like those answers.
Yeah, I think that's so common. And I think the waiting to get that information is just one of the worst parts of this diagnosis, that you are not right away there in the place that can give you all the answers that you need.
Yeah. Oh, it's so tricky. And like you said, it's not like it's anyone's fault. Like it's not like, I mean, it's such a rare cancer. And so the doctors who do find it, the optometrists, the ophthalmologists, the retina specialists who you might be referred to, they probably have never seen it either. So like they're just as shocked and confused, and it's just as abrupt for them as it is for you. But yeah, I mean, it definitely does feel a little, from a patient perspective, that feels really unsettling, I think, is maybe a good word for it.
Yeah, I think you're absolutely right. And I would say a good portion of my patients have even this other story where they didn't really have symptoms, or they got a
Hmm.
scratch on their eye and went in, or they just wanted a pair of new glasses and they went in. And this is completely unexpected. And, they then they have to live with this fear until they can get to the right place. And then
Well, I
it's a
can see
lot of
those
work.
patients. No, I just can see those patients maybe being, I guess, almost scared of the routine things in the future, right? Like that, the routine eye exams, just the basic dilated check, that those now those go from comfortable and normal and just routine to this is now something that could potentially be scary for me. And and I could see it translating to the routine exams of other areas of health too, like that would stop feeling safe. Um, I think, just that feeling of safety being gone, that feeling of feeling safe in your own body definitely goes away as soon as you get this diagnosis. Maybe not entirely for everyone, but like I think that across the board initially, it's very much a common feeling.
Yeah, I
Um,
think it's so important to talk about that too.
so as a physician, like, by the time they get to you, like you said, they have sometimes seen multiple providers. They've gotten the news maybe in the worst ways possible. Um, they've had routine eye exams. They've had potentially no symptoms and they're completely shocked. All of these potential scenarios. When they get to you, what do you like to do, or what do you think is most helpful as a physician to just kind of, I guess, almost like start with a fresh slate, even, just so that you can kind of reboot, like, okay, this is where we're at, and this is what we need to do.
Yeah, I really do. No matter how many times they might have heard things from their other doctors that they've seen before, I really like to start from the beginning. And so, I'll introduce myself, we'll say our hellos, I'll get my exam done, and then I want to have time to talk. I want to have time to have eye contact. And I love to talk with pictures. So I know, just as you talked about, it's so much work to get this diagnosis. You have to take so many images. It takes a long time. It's not always
Mhm.
comfortable. So then I want to show them, what we worked for. I want them to be able to see for themselves what's going on. And I think that's really important. So I will always pull up our pictures of the eyes. I will show them, this is your normal eye. This is where your center of vision lives. This is where your optic nerve is that connects to the brain. And this is your other eye. And then this is where we're concerned. And I love to be able to point to these spots. And then I'll go through and I'll show them, this is how it looks on an ultrasound. And I'll orient them, and we have models of the eye in our clinics. I can say, this is where the front is and this is way in the back. This is how big this is. And in reality, maybe this is the size of a dime or a nickel. And I try to equate it with something that's a little more tangible
Yeah.
so that we can understand. And I think that's so important. The other things that I really, really want to do for my patients, two of the most common questions I get, one is, why wasn't this found before?
Mm.
Because so many patients do go in for routine eye exams. It's one thing when you have the person who hasn't been in 20 years, and then we say, oh, this, that's such a bummer. But when you have somebody who goes every year, and then they say, well, how did this suddenly show up? I like to talk about details and location. Sometimes when you have something at the front of the eye, like yours was at the front of the eye, those things can hide even on a really good eye exam. And so I like to explain, why did that happen? Why could there have been something there that was missed even by a really good doctor? And then the other thing is, patients want to know, what did I do that made this happen? And I always want people to know, you didn't do anything. You didn't not do anything. Like, this is not your fault. You don't have to feel guilty. I get, is this because I smoked, or, I'm so healthy. I do all of these things. I exercise, I eat right. Like, what did I do wrong? And there's, I think, this tremendous feeling of guilt. Like, you might have brought this on yourself. And really, that's not the case. The reality is, a nevus or a freckle in the eye is really common. About 1 in 10 people will have one of these. And most of the time, it's just bad luck that 1 in 8 or 9,000 of them becomes a cancer. And, I talk about the rare scenarios. There are some very rare genetic scenarios, like the BAC1 tumor predisposition syndrome, or MBD4, that we're learning about. So I ask about family history and I offer genetic testing if that's appropriate. But most of the time, there really isn't a good reason. Most of the time, it really isn't fair, and it sucks. And I think it's important to acknowledge that it sucks.
Yeah. No, I feel like that's such a good way to put it, and I feel like that, the way that you're talking about this, like I can just kind of picture, like, and I'm just imagining, myself with you as my doctor, and not that my doctor did anything wrong. I honestly, I picked her because she was so empathetic, so compassionate, so detail oriented, and she was willing to just sit there and talk with me as long as I needed. And I think that that's kind of one of those things that we need, right? A lot of the times medicine is so slammed with patients that it's just fast, right? You have 15 minutes with your doctor, and everything goes so rapidly. But I think that that's maybe one of the benefits of such a rare field, is that you guys do specialize so highly, and you do get, I guess it's maybe, depending on the preference of the doctor, but you do have that option as a doctor that you can be a little more selective, and you can take that time with the patient. And I can tell just from you talking about this, that you find that incredibly valuable, both to yourself and to the patient. And that ultimately, like, helping to make sure the patient is, I mean, I say comfortable in quotes, like as comfortable as possible with this diagnosis, but also just feels acknowledged and heard. um, this isn't on our like discussion question, but is there anything, as you're going into this first initial diagnosis appointment with them, where you're really covering, okay, this is the official diagnosis. Like, I can officially tell you, you do have ocular melanoma of, whatever kind, choroidal, ciliary body, iris, and that we do need to treat it. Before you go into treatment options, like, do you ever suggest to patients that they, potentially take notes, or that they use a recording device on their phone, like just to be able to record what we talk, what you talk about? Or does that not really typically come up? I just am curious.
Yeah, that's a great question. I think a lot of times it's such a shock that that's not where our mind is.
Hmm.
And I just expect, I'm going to say this huge barrage of information. We have a really great patient pamphlet that I give to everybody. When we've looked at the pictures, I always allow people to take pictures on their cell phone of what their eye looks like, so they have that documented for them. But I just expect we're going to talk about this again. We're going to talk about this again and again and again. And if I have to go through the same information 5 times, that is fine. I have no problem with that, because so many times you say the word cancer and no other words go in. And I know that. But the other thing that I do for all my patients is I really do encourage them to come with somebody, to come with a spouse or with family, because I think it's really great to have other ears to hear. So I've had plenty of times where there are 3 or 4 extra people and we're getting extra chairs to put them in the room. And in the pandemic, this was always a thing because you had to get exceptions for this. But there are always exceptions to have people support my patients and my practice, because I think that's so important, just to have them be there with you, and because they're not as in shock as you are. So they can take in that information a little more readily. And oftentimes it's the family member that's there with the notebook taking notes.
No, I think that's such a powerful thing. I know that in the Facebook groups, at least, what we see a lot of people suggesting, take notes, make sure, you're going to forget all this information. But I love that you just as a physician expect that, like you said, that when you hear cancer, not much else goes in, and that, the options, the treatments, the biopsy for prognostication, all of the different systemic monitoring, all of that just doesn't sink in initially, and it takes multiple times, multiple moments of you repeating it, or the patients asking questions. And so I think that it's, I just can't tell you how many patients that I talk to who they feel somehow like it's bad that they can't remember what their first doctor appointment was, or that they just feel like, oh, I should be able to remember this, I just can't remember anything. And it really is, I mean, we probably would need maybe a psychologist to come and explain this a little better. I think maybe the one that we had at I Believe, she talked about this idea that when you get this diagnosis, oftentimes your brain is kind of a sieve, that it just kind of, everything just falls out, and the big stuff stays, right? The big stuff like cancer, well, I need my eye removed if that's the case, or I need this type of radiation or whatever. That big stuff, that main idea stuff stays, but it's the finer details that tend to slip through and that you just don't always remember right away. And that's perfectly normal and acceptable. I think that's what we're trying to get at here, is just from that physician perspective, from a patient perspective, it really is okay if that's the case. If there's nothing wrong with you, you just got a traumatic diagnosis, and it's really normal to have follow-ups, and to, I guess, to not feel guilty, right? Like, to reach out to your doctor if you have questions. Like, there's nothing wrong with reaching out and getting clarifying questions answered, even if it's the day before you're scheduled for plaque surgery or enucleation surgery, if you have second doubts, or you're second guessing yourself, anything like that, there's nothing wrong with contacting your doctor with that kind of question. Um, yeah. Anyway, I think maybe I'm maybe a little unique sometimes, in the sense that I don't think that everyone thinks the way that I do when I approach a medical situation, and maybe that's because I'm further into it, and so I approach it differently now than I used to. But I definitely, I guess I remember feeling hesitant about calling my doctor about questions to begin with. I don't anymore. But initially you feel a little hesitant because everything's new. It's a new person, but it's also a new person who, I mean, I think you talked in one of the previous episodes I had you on. You're like, I want to be able to see the patients, but I want to see them in 20 years. And I want to be able to tell them, in 15, 20 years, you're in the clear. And to have that kind of a relationship, right? Where this is the doctor I'm going to stick with for the rest of my life. Anyway, okay. Well, let's talk a little about the treatment options, and like, how do you present that information to patients? Now that you've gone through all the details, you've covered this isn't your fault. Um, what do you go through as far as talking about these options for treatment, and how do you present that?
So yeah, we always have several different options for treatment. It's rare that we're backed into a corner and the only safe option is enucleation. That's always one of the hardest conversations to have, when you really have to say the only safe thing I can do for you is remove your eye. That's probably the most heartbreaking thing. Most conversations are a little better news because patients are often afraid that that's what I'm going to tell them we have to do. And so it's nice to be able to say, we can back that up, and actually this is small enough that I think we can safely manage this with radiation, and we have several different options for radiation, the primary two which would be plaque radiation or proton beam radiation. And these two things are actually a really important discussion these days because potentially, although we're still working on what our evidence is here, there may be some circumstances under which proton might have a better vision outcome than plaque, or there may be some patients for whom plaque is a better option than proton. And so I think it's important to talk about the differences in risk. Proton has really strong radiation on the way in, but it doesn't have an exit dose. So you can control potentially a little bit differently where that radiation is hitting, versus a plaque is going to have these circular radiation fields that get a little bit less the farther away you go from the plaque. And so we're starting to have conversations. If your tumor is kind of close to your center of vision, can we sharp edge out your center of vision with the proton beam field of radiation and potentially preserve more eyesight for you? Or if something's around your optic nerve, we know that the optic nerve is actually larger on the outside of the eye than on the inside of the eye. So sometimes it might be hard to get a plaque really tight to the tumor margins there. So is proton safer for tumor control in those situations? Or for some small tumors that are farther away from the center of vision, I maybe can go a little lower on my dose and know that I'm going to still have a good response from a plaque than I can with proton. And so that may be a little bit better. So there's really pros and cons to all of these different things. And so it can be a detailed discussion, especially depending on where the tumor is. For things that are really small or indeterminate, then we start having conversations about things like lasers or things like the aura trial. And is this right for you? We know that things outside of the aura trial that we've tried in the past for lasers, maybe the risk of tumor recurrence is higher. It's not my gold standard of care to really kill a cancer, but we definitely talk about these things. We go through the whole gamut of what are the risks to vision with all of these different treatments, what's the long-term outlook. And these are things that I expect are kind of in one ear and out the other, but it helps to talk it through for someone to really come to a decision of this time sensitive thing that we need to decide soon what we're going to do
Mhm.
next for this tumor. I think one of the really big points that I emphasize over and over again, though, to my patients that I think is great to mention in this kind of platform is that removing an eye doesn't necessarily reduce the risk that the cancer is going to show up somewhere else in your body. And I think this is a common misconception because I have a lot of patients who say, well, if you take it out, then it's gone and it's done. And then I will never have to worry about it coming back. And I so wish that were true. I would love for that to be true. But the reality is, we actually have really good data that whether we remove the eye or whether we do radiation, the risk of something spreading is not going to change. And so I think I always bring my patients back to, we know we're going to watch the rest of your body no matter what. We're going to talk about this prognostic test, and we're going to do the best that we can to prevent metastasis no matter what. But today, what we have to make a decision on is really what we want to do for your eye. And so we have to keep these things separate. I think that's really important to
Yeah.
understand.
No, that's for sure important. It's important that we kind of cover that a lot of what we're talking about right now, like we're kind of covering multiple scenarios, but most of this is taking place in that first appointment. In that very first appointment, and obviously we can cover it, we can retouch it in follow-up appointments before, you know, whatever treatment happens. But I think the gist of what we're trying to show here is that there's the talk about, you know, getting the diagnosis and the feelings and the empathizing, but there's also the talking about the treatment and making sure that patients follow out, or they leave with a both a plan, knowledge of what's going on, and also a level of follow-up, like around things like the biopsy for prognostication, systemic monitoring. We've got, you know, other parts of the follow-up that would include the radiation, like side effect management, like, and those are things that you would potentially touch on a little in this first appointment, but they're maybe not the main focus, is what I'm hearing.
Yeah, that's exactly right. It's just such a tremendously large amount of information. And as you know, when you're feeling like you've just been given a cancer diagnosis, it's not always the right time to hear all of that information. So I want to give as much as I can without making it even more overwhelming than it already is that first day.
No, that makes total sense. So one of the questions we're getting from Facebook is just asking, you know, do you prefer to talk about the biopsy before treatment, like this biopsy option for prognostication? How do you approach talking about that with your patients?
Yeah, so I always talk about that also in this first visit. I mean, it's really a lot, and just as you said, I so value having that time. My clinic does not always or often run on time at all, but it's really because I feel that it's so important not to cut people off and not to shorten this conversation. So I do talk about that. We kind of go through and we get an idea of, okay, what treatment do we think we're heading toward? And then I'll usually say, okay, so now that we know where we're heading, we have an option to do this biopsy. And it's not really to tell us what the diagnosis is. We've already found what the diagnosis is, but it's really to tell us what is the risk of cancer spread someday. And so depending on what we're doing, if we're removing an eye, then it's really easy. Then we can send a slice of your tumor from the eye that we removed to get the test. No extra time or effort for you. If we're keeping an eye, then we usually talk about the risks of biopsy, what that can sometimes mean for your vision, what that can sometimes mean for if you need second procedures later, because there's always a small risk. Anytime we do a biopsy, we do have to take a tiny needle and suction out some tumor cells. And sometimes some of the ways we approach this are to go through the retina. The retina doctors might do this actually sometimes with a vitrectomy. So in some hands, it's a bigger surgery, and some hands, I do a fine needle aspiration biopsy. So there are many different ways to do this, and it's important the patient understands exactly how their doctor is going to do that and exactly what risks that might come with. Anytime we're going into a tumor, there's always a chance that it can bleed. So I talk about, are you on blood thinners? Because that's important to me. I can put a plaque on, I can put markers on for proton on blood thinners, but I don't love to do a tumor biopsy on blood thinners because this can make a big difference in how much you bleed inside the eye. And a big bleed inside the eye can cause big scarring that can cause vision loss right away. That doesn't come back. So we always have to talk about that. Anytime we go through the retina and we make a tiny hole in the retina, we have this risk that we're going to end up with a retinal tear type of retinal detachment. And that risk is pretty small, but I always have to cover that because there's a small chance that if that hole doesn't heal, that we'll need a second retina surgery to reattach the retina. So these are important things to think about. And then the other important thing is, what is that information going to mean to us and what are we going to do with it later? And so I talk about, if we're in a high risk category, that means we're going to want to scan your lungs or liver more like every 3 or 4 months, a lot more often than if we're in a medium risk or a low risk category. And that might mean that you're eligible for clinical trials of medicines to try to reduce that risk of spread. And if we don't have this information, then you probably can't have those types of things. And then it's important to know that we can only get that information accurately before we treat the cancer. Once the cancer is treated, we can't go back and get it later. So unfortunately, it's this other extra choice that we really have to make in a time sensitive fashion before we treat the tumor.
Hmm. So I know you talked, generally about the risk um, that the biopsy can hold, mostly, to things like bleeding in the eye, things like that. There is definitely noise. We'll put it that way. There's definitely noise on social media that talks about this idea that, oh, if somebody is told they can't have a biopsy, somewhere in the mix of this, many patients have interpreted that to mean that that means that their tumor would have spread, that the biopsy would have caused the tumor to spread, to activate it in a way that it actually is more active and goes and spreads to the rest of the body. So can you maybe dispel that rumor a little bit, because everything that the research tells us says that that's not the case.
Yeah, that's really not the case. Can we have accidents where someone doesn't know there's a tumor and they put a vitrectomy port through a tumor and that causes the cancer to come outside the eye? Yes. And I think all of us have at least heard of that happening somewhere at some point. But when we know there's a tumor, when we're doing a biopsy intentionally, and when it's in the hands of a trained ocular oncologist who's used to doing this, we really don't believe that doing that biopsy increases the chance of cancer spread. And we take really good measures to make sure that we're going to be safe about this. So if we're going through the white of the eye, the sclera, directly into the tumor, I always do freezing directly around that needle hub before I come out of the eye. So no cancer cells can escape the eye. If we're going in through the front of the eye, or if they're doing a retina approach, those cancer cells aren't going to reach that little hole that we went into in the front of the eye. So we know how to take all of the safety measures. And there's nothing about puncturing a little hole and suctioning out some cells of the tumor that's going to make it more likely to spread to other parts of your body. So I would absolutely never say I don't want to have a biopsy because I'm worried that it's going to increase the risk of cancer spread. I think it's very reasonable if you have a very small tumor, if it's in the center of your vision, if you say, because it's small, I know it's probably low risk to spread anyway, and I would rather not take a risk of big bleeding by my center of vision. I think that's a very reasonable choice. But if you're young, if you have a large tumor, I would really recommend that this is great information to have, because if we have a trial or if we have a drug that could reduce your risk of metastasis, I would really want you to be able to have that.
Yeah, well, and that is contingent oftentimes on what is your prognostication from the biopsy. So, I really wanted to have someone come on here and explain that, because I've seen that just so many times the last couple of months in Facebook off and on, and I'm like, okay, we gotta talk about this. And it goes back to what you said too, the difference, like kind of the difference between plaque and radiation, or plaque radiation, proton beam, and enucleation, that isn't reducing the risk of spread. Like, it's still largely the same either way. And that and you can maybe just correct me if I'm misinterpreting this, but that generally means that if the cancer does show up later, whether it's 5 years, 2 years, or 15 years later, it's not because it spread after or during the treatment. It's because it already had done so. We just didn't know it at the time. It had, seeded in the body well before we ever found it in the eye.
Yeah, that's really what most of us believe, and I think you're going to see the face of how we monitor that shifting rapidly over the next couple of years, because we can detect cancer DNA in the blood now, and I think we're going to eventually have tests that actually allow us to pick up this cancer spread that may have already occurred before we can actually see it on our scans. And I think we're going to be able to treat earlier because of that. So I really think that the game is going to change. But I think you're absolutely right. I don't think it's coming from the eye. I don't think it's coming from any procedure that was done. For whatever reason, this cancer can hide in the bloodstream and evade our ability to detect it for many, many, many years.
Yeah, and it's so trippy, right? And that can go back to kind of what we talked about at first, of like, well, did I do something? Did I do something wrong? Did I not do something? And when you put it that way, it kind of both feels a little bit like a, I don't know, like a, okay, well, like I didn't have a chance at knowing, until we have more information, like you said, until we have more information where we can do this in a routine blood exam, and it can just be okay, you have a risk of this or that. until we have that, or we have a way to detect it floating around in the bloodstream, there really is no way to know if it's there or not until it is detectable. Whether it's detectable in the eye or detectable somewhere else because of metastases. And it really, I mean, but as a patient, that can really feel a little bit like, so I had no chance, almost, I guess, is kind of the phrase that comes to mind, is like, okay, so like I there's no way for us to have known. And so when it was found in my eye and it was already this big and the location sucked because of whatever reason, like it just kind of, I'm trying to think of like the way to put this, but it generally just feels kind of like I was screwed before I knew it. In some ways, or at least, maybe just that prognosis risk factor was already there even though I didn't know it. um, and that can feel a little defeating, I think, to some patients, for sure.
Yeah, I think that's absolutely correct. That is how it feels. And that's sometimes how it feels to us too. The best thing I can do is treat a tumor when it's the smallest that I can find it. But
But
it
finding it that
sucks.
small every time.
Right. It sucks that I can't go back in time and make everything smaller. It sucks that no matter what I do for the eye, it's not necessarily going to change that metastatic outcome. But I think the game is changing. I think we're
Yeah,
getting drugs that work. I really think it's happening now, and it's going to
yeah.
look so much different in 5, 10 years.
Well, I'm just remembering you talking earlier this year, like just if we go back to, I feel like even just the summer, like when we had you come on for the Ion Research Convention, like that we did our small seminar here, like you were just talking about how like things are rapidly changing. And I think those were maybe the things that we can now talk about now because they've been presented on. But even back in January when we had you come on and talk about the living library, like that you're creating and the research that you're doing there, and what you hope that will come of that, like you already had this kind of idea of like things are changing so fast. And I think if we really look back just at this last 12 months, like so much good has come in the world of ocular melanoma. And it is no longer accurate to say that if you get this diagnosis, that this is end all, like worst case scenario, there's nothing we can do for you. Like there are so many good options. Are there as many as maybe other cancers? No, but like we have so many more than we used to, and there's just a lot more rapidly happening. So I hope that we can maybe leave on a hopeful note with that, of that idea that like there is so much that is coming, and I really cannot wait to see what 2024 brings.
Me too, with what we've done in just 1 year. I mean, you're so right. I'm so glad you put that into perspective, because if just 1 year can do this much, just think about where we're going to be in another 12 months from now.
Yeah, exactly. It's so powerful. Well, Dr. Davlin, I feel like this has been so wonderful, and I want to be respectful of your time. So, is there anything you want to end with other than what we just had?
I think this has been fantastic, and I'm so thankful again for the opportunity to do this. I hope that people are able to connect with this. And I love hearing your story. I love hearing my patients' stories, and I hope I get to hear all of the stories changing over the next several years. And as we end on this hopeful note, I hope
Yeah, no,
that
I love
I'm
that.
going to get to fulfill that dream of seeing all of my patients reach their 15-year cancer-free mark.
No, that would be amazing. Love that. So thank you again. Thank you, those of you, not us, those of you who are listening in on Facebook. Please share this with your physicians. If you like, we had a couple people come in with comments saying, oh, there's still doctors and oncologists giving inaccurate info about the biopsy. Please send this to them. Help inform your physicians. Help inform their teams so that more patients can, or just share it with patients in their offices so that they can hear from other doctors. And I guess I did want to ask you, if you have a sec, for one last question. How do you, when you have a patient and you're going through this initial appointment, do you ever at any point suggest that they get a second opinion or offer that as an option? Because I do think that there's some noise here on the Facebook talking about like, oh, I wish I had shopped around. Like Dr. Dalvin isn't so far from me. Wish I had gone to her. Like, anyway, so what's your perspective on that?
Yeah, I think if you ever feel uncomfortable, it is always okay to get a second opinion. Most of us who do this all the time, we know each other. Most of us think very similarly, but we're not all the same person. We're not all the same personality. We're not all the right fit for every individual. And you have to feel comfortable. I'm never going to feel offended if I'm not the person who makes you feel most comfortable, or if you don't want to wait for me when I'm behind. I completely understand. So, I think you have to be your own advocate. You don't have to feel guilty if a doctor's office is not the right place for you. There are places that do this. It's not only that one option. I've had plenty of people get on a plane and fly to Boston or fly to Philadelphia because they want to hear from somebody else what they would do. And so I think never feel bad if you want a second opinion. Never feel bad if you want a third opinion. It's your body, it's your life, and you have to feel like you have the right fit.
Yeah, that's such a powerful thing. And then the last question, we referenced the living library, so I think I can point you guys back to the podcast episode. But if people wanted more information on the living library itself, how would they best get in touch with you or your team?
Yeah. So, my email, if you email me, I can pass it on to our lab team, but my email's pretty easy. It's just dalvin.lauren@mayo.edu. And I'm really happy to say that we just got a modification approved where we can do emergency acceptance of samples coming from anywhere. So
That's
that's
so
really exciting.
exciting. That's so exciting. Okay. So, yeah, for those of you who want more information on the Living Library, head back to January of this year on the podcast episodes. You can listen to, I want to say it's like episode 40 something, maybe 50 something. It's pretty close to that area. I'm like ballparking it. But if you head over to the podcast, you can listen there. You can learn about it. She presented a whole webinar on it in January. And then, like she said, email her directly at dalvin.lauren@mayo.edu. Um, and with that, we will go ahead and end, and we will see you guys next time.